Welcome to Ross University School of Medicine's Procedural Skills Introduction to Suturing Lecture Presentation. I am Dr. Brenton Otey, and I will be guiding you through this lecture today. Here is a look at our outline, which covers everything we will discuss today. In terms of our objectives, our goals are to outline the stages of wound healing, to outline the types of suture material used for wound closure, to demonstrate wound closure preparation, to demonstrate basic suturing techniques, and to provide supplementary materials useful for clinical rotations. Let's start by talking about the stages of cutaneous wound healing. Phase 1 is inflammation. Injury causes platelet adhesion and aggregation to form a clot. For phase 2, we have proliferation. This is the formation of granulation tissue and migration of connective tissue cells, as well as re-epithelialization of the wound surface. For phase 3, we have maturation. The extracellular matrix deposition occurs, and tissue remodeling and wound contraction also occurs as well. Now, let's continue with the types of wound healing. First intention is a wound closed by routine suturing, stapling, or gluing. And epithelialization is achieved within 24 to 48 hours. First intention is also known as primary intention. Moving on to second intention, this is when a wound is not closed by sutures, glue, or stapling, but closes spontaneously by wound contraction and epithelialization at a rate of approximately 1 millimeter per day. This is most often used for infected wounds. Third intention, also known as a delayed primary closure, is when the wound is left open and sutured at a later date, usually 3 to 5 days later or more. This will allow for the gross contamination to subside. Let's look at our instruments for suturing. Here we have the scalpel. The number 10 blade is the sharpest of all the scalpels at its belly and is used for large incisions. The number 11 blade is used for small incisions of incision and drainage. And then we also have a number 15 blade, which is also commonly used. Most skin surgery is performed with a number 15 blade, as the number 15 blade is sharpest at the tip. Okay, so we talked about the scalpel. Here's our needle driver. There are multiple ways to hold the needle driver. There's the palming technique, with the handles resting in your palm. Your index finger is extended and rests on the fulcrum of the needle driver. This allows for maximum mobility. You could also use the thumb and ring technique. This is where you hold the needle driver with the thumb and the ring of the needle driver, but your third, fourth, and fifth digits are used to palm the other ring. Your index finger is pointed along the length of the needle driver and rests at the fulcrum, much like that described in technique of what we just talked about with the palming technique. No fingers are inserted in the other ring. And then, of course, there's the classic thumb, ring, finger technique. The thumb in one ring and the fourth digit in the other ring with the index finger pointed. And there are no techniques where the second digit is in the second ring of the needle driver. The image on the left is a representation of what the palming technique for holding the needle driver would look like, and the image on the right is an example of the classic thumb ring finger technique. We also have our forceps. The forceps with teeth are good for manipulating tissue, and the forceps without teeth make it more difficult to manipulate and may lead to tissue damage from crush injury. So in the picture on the right, you can see a close-up of the teeth of the forceps. We also have suturing scissors. These are for cutting sutures, commonly found in suture kits, but not part of a surgeon's array of tools in the operating room. We also have iris scissors, which can be used to cut pathologic stones. And then, of course, the Metzen bombs, which are round-tip scissors for cutting and separating or spreading tissue. Now, sutures come in a variety of different materials, which vary in knot security, duration of how long they can keep the wound secure, how reactive they are with the tissue, and so on. Knot security is the ability of the suture material to maintain its placement without loosening. Tensile strength is the strength per unit area of the suture material. It's also important to note that there are other materials that can be used for wound closure, including metal staples, wound tapes such as steri strips, and wound adhesives such as Dermabond. Let's talk about the different sizes of the suturing material. There's a variety to choose from, and depending on which size you're picking determines what it can be used for. When reading the sizes, you may notice it may say, for example, 4-0. To pronounce the suture size, 4-0 is pronounced 4-0, and etc. for 5-0, 6-0, 7-0, and so on. Different sizes have different uses. Now let's talk about the needles. There's three main components of a needle. There's the body, there's the point, and the shank. A shank is a hollow area where the suture is swaged and held in place. And a swage is a groove or... Surprisingly, we also have a variety of different needles which serve different purposes as well. For example, a cutting needle has the cutting surface on the concave side of the needle. We also have a reverse cutting needle, which has the cutting surface on the outside of the needle. And also keep in mind that tapered needles go through the skin with less trauma, leaving a smaller path of injury. Here is an example of what your average suture packaging would look like, with all the relevant information listed, so when a surgeon or resident asks for a particular suture, you can find it based on the labels. Here are your components for wound preparation. You're going to position the patient and clean the wound, drape them, keep in mind to always use sterile technique, anesthetize the targeted area, and then suture the wound closed. There's a variety of different suturing methods. The first one we're going to look at is the simple interrupted. You're going to start by introducing the needle perpendicular to the skin, approximately 0.5 to 1 centimeter from the wound, and exit within the wound. Then you're going to reinsert the needle within the wound on the opposite wound edge and come out at the same distance, about 0.5 centimeter to 1 centimeter on the opposite wound edge. Be sure to enter and exit at the same levels on both wound sides to ensure proper wound edge eversion. The more deep of the bite, the better you will be able to get the wound edge eversion. The path of the needle will be on an arc, but to help create wound edge eversion, you will pull the skin towards the midline of the wound before taking a bite with your needle, which creates an Erlenmeyer flask type of look, as you can see pictured here. This next slide goes into a little bit more detail on wound edge eversion. To create wound edge eversion, it is important to enter at a 90-degree angle perpendicular to the skin to create the bottle or Erlenmeyer flask-shaped suture path like we discussed previously. Wound edge eversion is important because it helps to ensure that as the wound heals and the scar contracts with remodeling, that the skin surface heals flat instead of creating a crevasse as shown above. Next we have instrument tying, and you're definitely going to need to get out your tools and practice this one a couple times before you get it down. To tie your simple interrupted suture, it is easiest to perform an instrument tie as it is quick, easy, and saves the suture material for your next sutures. You're going to start by pulling the needle end of the suture through after you have taken both bites. Pull until the other end of the suture without the needle has a small tail approximately 1 inch long or so. Then, place the needle driver parallel to the wound between the two ends of the suture, the needle end and the tail. With the needle end, wrap the suture material around the end of the needle driver twice. This is to perform the surgeon's knot. Some people will tell you to wrap clockwise or counterclockwise. This may be confusing as it will all depend on which side of the wound you are working on, and it may differ if you are right or left-handed. The most important principle is to understand that you are taking the long end of the suture material and wrapping it over the instrument, not under, back towards the midline of the wound. Then, with the two loops around the needle driver, open the needle driver and clamp it on the short end of the suture and pull it through the looped ends. This can be assisted by moving your hands. Pull your hands in opposite directions to lay the first half of the surgeon's knot flat, and your hands should now be on opposite sides than where they started. This is only one half of the surgeon's knot and will not stay if left in place. To complete the knot, Bring the needle driver back in between the two suture ends and hold it parallel to the wound. You will now wrap the long end of the suture in the opposite direction that you just did, over the needle driver just once to create the loop. Then, as before, open the needle driver to clamp the short end of the suture and pull it through the loop to once again lay it flat on the wound. Your hands will be able to pull the needle driver and suture in opposite directions again. Cinch down on the suture to leave the wound edges everted but not too tight, strangulating the tissue. This is the complete surgeon's knot, which required 2 separate motions. To add security to the knot, you can continue the last step of the surgeon's knot with a single loop around the needle driver and alternate back and forth with the directions of your hands to lay the knots down. This time, however, every single knot counts as one security knot as opposed to the first 2 that were required to complete the surgeon's knot. An important tip to help with maneuvering the suture material: if you hold the needle driver further away from the wound and wrap the suture material around it, to move in order to pick up the short end of the suture and prevents creating loops with the free end if you left it too long to begin with. Here on this slide, we have a picture of what a completed surgeon's knot would look like. Now let's talk about suture distances. The bigger the bite you take, the more secure the suture will be. 1 centimeter away from the wound is where you should aim for. Each suture should also be about 1 centimeter away from the next so that the distance from suture bite to wound and distance between sutures is equal. Bisecting the wound is done to approximate tissue by placing the next suture in the midpoint between ends of the wound. By doing this, it helps to keep the tissue well approximated and prevents dog ears. To give a little more insight, dog ears occur when the wound is closed in a fashion that starts from one end and goes to the other. One side of the wound is disproportionately closed tightly, leaving extra tissue on the opposite side of the wound at the end. This creates a flap of tissue that looks like a dog ear. These dog ears can be corrected easily by making a small incision to extend the wound and then rotating the flap of tissue. But it is best to avoid having to extend the wound by using the bisecting method. Now let's talk about the running continuous. This is a type of suturing which can be used for longer wounds that need to be closed quickly. You could use this in a pediatric patient as well as a patient who won't sit still. But this type of suturing is used less commonly as staples are very effective at closing long wounds quickly. To perform a continuous closure, start at one end of the wound with the simple interrupted suture. Once finished tying the knot, cut only the shorter end, the non-needle end, to 0.5 centimeter. Then pull the knot to the side of the wound opposite the side you will take your next bite. This will ensure the suture remains tight and won't loosen. Take your next bites in succession perpendicular to the wound. Aim for 45-degree angles so that when you are done, the suture laying above the skin are all angled and the sutures underneath are all placed perpendicular to the wound, just like with the simple interrupted sutures. At the end, leave the last loop a little loose so that you can tie your knot using the needle end of the suture and the loop of the last one as your other tail. Once you tie it, just as you did for the simple interrupted, cutting the suture ends will produce 3 tails in total. Here we have a locked continuous. This is a specific type of running continuous which is used commonly in obstetrics after a C-section to close the uterus. Now we're looking at the horizontal mattress suture. Horizontal mattress sutures are good to use on areas under high tension like the back of the elbows, or if there is significant edema, or where some tissue was lost from blunt trauma, or maybe it had to be cut away because the tissue approximated was devitalized from trauma. Horizontal mattress suturing starts exactly like a simple interrupted, except once the 2 first bites are taken, the needle is reversed in the needle driver, and you backhand the next 2 bites, so that the needle end of the suture and the smaller tail end up on the same side of the wound. Here's the vertical mattress suture. The first bite is taken from the wound edge and it comes out within the wound. The second bite should enter the wound and exit on the opposite side of the wound, equidistant from the first bite. You have, in effect, taken 2 bites far. Then reverse the needle and take the second 2 bites at equal distances from the wound and depths. Note the picture displays only 1 reverse bite, but this may be more difficult for learners as it may result in unequal amounts of tissue being approximated on the 2 sides of the wound. The vertical mattress suture allows for great wound approximation with little tension, but may produce more scarring. Here we have the half-buried horizontal mattress suture, also known as the corner stitch. The half-buried sutures are a variation of the horizontal mattress suture and are used to approximate the point of a flap of tissue. Here on this slide, we have an example of a subarticular suture. This slide is used to highlight how to start and finish deep buried sutures. This is commonly used when approximating deep layers of tissue before approximating superficial. And here we have an example of staples. Staples are also an effective way to close wounds quickly. In terms of staple removal, we have an example of what it looks like when a staple is in place and the staple remover, and what it looks like to the staple after it has been removed. As you can see, it's been reformed. These are timelines of when suture should be removed based on location of placement. Keep in mind these are suggested timelines and many sources vary slightly. Specific patient characteristics may also dictate when the sutures will be removed. The following slides contain supplementary information that you may find useful. Some factors affecting wound healing include systemically there could be nutrition issues such as protein deficiency or vitamin or mineral deficiencies, which inhibit collagen synthesis. The metabolic status can also affect the wound healing, circulatory status of the patient, and hormones and glucocorticoids can also affect it as well. Some more local factors that can affect wound healing include infection, mechanical factors, foreign bodies, and the size, location, and of course the type of wound itself.